Okay, so this video is to talk about the clinical manifestations of infective endocarditis. Okay, the clinical manifestations of infective endocarditis is due to one of two things: due to the general or non-specific infection, okay, or due to the vegetation effect, or the effect of the vegetations that results from the or predispose for infective endocarditis. Let's start with the general or non-specific symptoms, like any symptoms of any infection: the fever, the malaise, okay, arthalgia, the weight loss, myalgia. All of them can happen, but they are all non-specific. This fever may be prolonged fever, okay. So the vegetation effect is due to the microembolization of the vegetation or due to the immune response. 50% of the clinical manifestations of the infective endocarditis due to the microembolization from the vegetation that result, okay, or from immune response. Heart murmur. You know that the vegetation is in the heart valves, and the murmur is mostly due to abnormal heart valve closure and opening. So heart murmur is an important clinical manifestation of infective endocarditis. In hand, what can we see in hand? We can see splinter hemorrhage, streak of blood on the nails, okay, due to embolization in small vessels of the fingers. We can see what we call Osler nodule. Osler nodule is actually a tender, red nodule, okay, at the end of finger or toes. So it is very important to know that it is tender, it is painful nodule, red, where? On the end of fingers or toes. This is the Osler nodule. It is tender, okay, and red. I just stressed on tender because we have other lesion on the hand, which is Genoa lesion. Genoa lesion is small but painless. It is non-tender, okay, hemorrhage on the palms or soles. Okay, so this is Genoa. It is painless. The Osler nodule is painful. The Genoa lesion is painless. The Osler on the tip of fingers or the nails, okay. The Genoa is on palms or on soles. Okay, what also we can see in hand, clubbing of the fingers, okay, and okay, the microembolization that may go to the lung may lead to pulmonary embolism, dyspnea, and the symptoms of pulmonary embolism. If the microembolization goes to the brain, may lead to seizure or hemiparesis, CVA, and so on. Splenomegaly, okay. In renal arteries, the hemorrhage or the embolization may lead to hematuria. It's common finding to found microscopic or macroscopic hematuria, the case of infective endocarditis. In the eye, we can see retinal hemorrhage. Actually, this is a very good picture or a graph that shows you from head to toe what symptoms or what clinical manifestation we can see, okay. And in the head, we can see in the brain cerebral hemorrhage, okay. On the eye, we can see retinal hemorrhage, which is Roth spot, okay. On the mouth, we can see petechial hemorrhage on the mucous membrane. On the heart, we can see some vegetations, murmurs, okay, murmurs of regurgitation, new murmurs, okay. On the spleen, we can see splenomegaly. On the kidney, we can see hematuria. On the hand, we can see the Osler nodule, the Genoa lesion, or clubbing of the hand. Okay, also on the feet we can see petechial rash. Okay, so splinter hemorrhage also on the fingers. What is that? Is Osler nodule. After clinical manifestation, let's now move to the laboratory findings that we may find in infective endocarditis. The most important laboratory finding is the blood culture. Okay, so it's very important to have blood culture in infective endocarditis. Continuous bacteremia or fungemia depends on the organism. Okay, we have to take multiple blood cultures, not one blood cultures, and these multiple blood cultures have to be taken before the starting of antibiotics, because the usage of antibiotics may mask the blood culture, may be negative when we use the antibiotic. Okay, despite the taking of adequate blood cultures, we may in 10 to 15% of cases have negative blood cultures, though we still have endocarditis. This is a clinical negative endocarditis, and that happens with some distinctive microorganisms. ESR and CRP are expected to be elevated often in endocarditis. We also may have leukocytosis. It's an infection. Okay, so ESR, CRP, leukocytosis, anemia. Okay, it's very common in infective endocarditis, mild anemia actually. We may have hematuria, as I said, okay, due to the hemorrhage in the kidney. We may have positive rheumatoid factors and positive anti-nuclear antibodies. Okay, positive rheumatoid factor, anti-nuclear antibody, ESR, CRP, leukocytosis, hematuria, anemia, and the most important, the blood culture. On the other hand, we have an echocardiogram. Echocardiogram is very important in infective endocarditis to see the valvular vegetations. Okay, it's very important. We can visualize the valvular vegetation by echocardiogram. Okay, and they will be more than 2 millimeters or greater cardiac vegetation. This is all about the laboratory findings and infective endocarditis and the clinical manifestations of infective endocarditis. In the next video, I'm going to talk about the diagnosis of infective endocarditis on Duke's criteria, modified Duke's criteria, and the differential diagnosis of infective endocarditis, the treatment of infective endocarditis, and the complications of infective endocarditis. Thank you very much for watching this video. See you in